Good morning again. Thank you for having me. I'll be talking about innovations in surgical care for lung cancer. One disclosure, I am a consultant for Intuitive Surgical, which makes the robot that I will talk about. So I decided to focus my talk on the changing landscape in thoracic surgery. Here's a picture of a CT scan and PET for a standard patient that we used to see all the time in our clinics, and even the non-radiologist may be able to spot the tumor here. And if you didn't, you could at least see that it's very avid on the PET scan below. And the standard treatment for a tumor like this would be removing the entire lobe of the lung that the tumor is in to make sure that you have the entire tumor as well as all of the lymph nodes that the tumor might have spread to. Nowadays, however, in my clinic, I frequently see tumors like this. Can you spot the tumor? So this is a less than 1 centimeter tumor in the right upper lobe, and it is part solid. You can see that it's not bright white, it's more hazy, so something we call ground glass. And so this type of tumor we're seeing more frequently as we're getting more diagnostic scans and finding them incidentally or doing more screening scans. And the question is, how much lung do we need to remove? Do we need to remove lymph nodes if a tumor is this small? So today I'll talk about 3 strategies that we've developed for smaller tumors: sublobar resection, tumor localization, as well as robotic surgery. So what is sublobar resection? Here's a picture from Gray's Anatomy of our lungs with the 3 lobes on the right and the 2 lobes on the left. And we used to do a standard surgical resection for cancer to remove an entire lobe. But actually each lobe that has an artery, a vein, and an airway leading to it is actually made up of segments. And each segment has an artery, vein, and airway leading to it. And so when we talk about the extent of surgery that we do, this can range from the smallest surgical resection that we do, which is called a wedge resection, just taking a wedge of the lung without worrying about the anatomic structures, to a segmentectomy where we take out 1 segment and we find the artery, vein, and bronchus leading to it, the standard resection, which was lobectomy, and then, of course, taking out 2 lobes or an entire lung, which is called a pneumonectomy. And so the smallest 2 resections, wedge resection and segmentectomy, we call a sublobar resection. A wedge resection is non-anatomic, but the rest are anatomic. So with the anatomic resections, we end up taking a little bit more lung, and we also get more lymph nodes. So if there's any concern that there's lymph node disease, it's really important that we do one of the anatomic resections. So we used to do sublobar resections for patients who could not tolerate a larger resection. So if they were heavy smokers and had poor lung function, or they had a lot of other medical problems, then we would do a sublobar resection for those patients. But more recently, we've been doing sublobar resections for these patients who have these really small lung nodules. We don't want to remove a lot of normal lung to treat such a small tumor. And for a while, we were doing it without a lot of data that showed that that was okay. It just seemed like that should be all right. A couple years ago, we finally got data from 2 large randomized trials that showed that sublobar resection is, in fact, non-inferior to lobectomy. So this is one of them from the CalGB or Alliance group, where they enrolled almost 700 patients from a multi-center study. These are patients who had peripheral tumors that were less than or equal to 2 centimeters. And when they got to surgery, the surgeons checked their lymph nodes, and if they were all negative, then they were randomized at that time to either sublobar resection or lobectomy. And the sublobar resection of choice was up to the surgeon. They could do either the wedge or the segmentectomy. And in fact, they found that the disease-free survival and the overall survival were very similar. And so this gave us some better understanding of sublobar resections and more data to share with patients when we were making the decision about how much lung to remove. Now, with sublobar resection, it's really important that we know exactly where the tumor is, because we're not taking out the entire lobe, we're only taking out a small piece. And so tumor localization or identification during surgery became much more important. And you can see this small tumor that I showed would be almost impossible for us to find during surgery. We can't see it on the edge of the lung because it's a little bit deep. It's hard to feel because it's ground glass and not solid, and it's quite small. And with our newer, minimally invasive approaches, it's really hard to actually feel the entire lung compared to our previous open operations where we could put our hands into the chest. And so surgeons have developed a few different ways to localize tumors. I'll share with you a few that we use currently. So this tumor, in fact, we localized with CT-guided methylene blue fiducial marker. So you could see in the middle column on the top, that's the CT-guided needle that's going into the tumor and dropping a metal marker that has, and also injecting some blue dye. And then in the middle column on the bottom, you can see our intraoperative camera picture, and that lung is stained a little blue. It is a little hard to see, and you can see the surgical instrument there. So on the upper right is a fluoroscopy or an X-ray picture in the operating room, so you can see the instrument, and then that black dot is the metal marker. And so we can make sure that we have enough margin, enough normal lung away from that nodule. That bottom right picture is the specimen of a wedge resection, and so you can see the staple line across the top where we've cut the lung and sealed it closed, and then that dark spot is the metal marker there. More recently, we've been using bronchoscopic ICG fiducial markers, and my colleague Ermina Elliott, who will be here tomorrow, has been studying this in depth. And here you can see another example on the top left. Let's see. I don't know if I have a pointer, but it is another ground glass nodule that is close to the surface. And actually, you could see on the bottom left, that's a picture after the fiducial marker has been placed. So this is a larger marker that has been soaked in indocyanine green, which is a fluorescent dye. And then during the surgery, again, we see the lung here, and we use a fluorescent camera, and we can see the fluorescence. And so that will show us where the nodule is and where we can do the wedge resection in order to get an appropriate margin around the tumor. One method of tumor localization that is under research and newer is molecular imaging. So using this technique, an imaging agent is given intravenously and localizes to the tumor, and that's given before surgery. And then during surgery, we use a fluorescence camera to detect the signal, the fluorescent signal. And one of the benefits is that this does not require radiation during the operation to find a metal marker. It doesn't require an additional procedure of the bronchoscopy or the CT guidance, and it doesn't require any other equipment because we can use the fluorescence cameras that are already built into our surgical cameras. This also has the potential to identify any tumor, not just the tumors that we see on preoperative imaging that we've marked specifically, because the imaging agent should go intravenously to any tumor. And Carolyn Chang, one of our residents, will be talking about our molecular imaging agent under study here at the Junior Investigator Roundtable tomorrow. So pafolacyinine is the first molecular imaging agent that has been approved by the FDA for lung cancer. And you can see a couple pictures here, representative examples of what you see under the regular white light on the left, and then what you see with the fluorescence camera on the right. And so in this study that they did of 112 patients, 19 patients, the tumor could not be seen under white light or palpation, but they could be found using this imaging agent. So finally, I'll talk about robotic thoracic surgery, and here are some graphs of The approaches that thoracic surgeons have used over the last decade or so, since the fourth generation robot was introduced, for various types of procedures. So the top left, for example, is lobectomy, top right is segmentectomy, bottom left is wedge resection. And the open approach is in dark blue, VATS, video-assisted thoracoscopic surgery in gray, and then the robotic approach in light blue. And you can see that the robotic approach has been increasing dramatically over the last decade. Just in the past few years, more lobectomies have been done in the US using the robot than any other approach. And this is especially true in segmentectomies and wedge resections, our sublobar resections. So I'll give a brief description of robotic surgery. On the left, you can see our traditional approach for lung cancer resections through a large incision called a thoracotomy, where we would make an incision between the ribs and actually spread the ribs apart. And you can see the surgeons leaning over and looking directly into the surgical field. In the middle, this is Mark Berry, who will be part of our panel, operating, doing a video-assisted thoracoscopic surgery case, or VATS. And this is done using small incisions with a camera. And so you can see they're not looking into the field, they're looking up at the screens. And they're using these instruments that have a long, thin component that can fit between the ribs without actually spreading the ribs open. On the right is a robotic approach. And so here we put ports in and we're using a camera again, but the robot is holding the camera and the instruments. And then the surgeons are actually sitting just a few feet away at consoles, looking in at the video feed and then using these hand controls. And one of the benefits of the robot is that the instruments are wristed, so you could see this instrument has wires at the end and actually can flex in ways that the other instruments cannot. Here's a picture of a recent robotic case. So you can see it's not a real robot in that it's not making any decisions, it's not controlling anything, but it is a great surgical tool. So you can see we're taking out a lymph node here. This is a left lower lobectomy, and we've divided the fissure. So screen left is the upper lobe and screen right is the lower lobe, and in the middle is the pulmonary artery. And so we're removing lymph nodes in that area, and then our goal is to actually find the branches of the pulmonary artery that are leading to the lower lobe and dividing those. And you can see in the picture of the actual operating room, that's me at the console working now, and then my resident is at the dual console right next to us. And at the patient's side, you can see the larger robot with the white arms going down, and there's a surgical nurse who is preparing all of the instruments for us, and then a robot physician assistant who's at the bedside. So she is exchanging instruments. When we remove a lymph node, she's the one that is physically taking the lymph node out of the body. I'll just pause for a sec so you can see what our surgical stapler looks like. This is one that we use to divide all of the structures in both VATS and robotic surgery. So I have handed control over to our resident who is now controlling, and you can see I'm carefully watching here. And so we've gotten the instrument around the branch of the pulmonary artery. And the PA, the physician assistant at the bedside, is getting the stapler ready. And then she's going to actually put the stapler into the robotic arm. And then carefully bring that into the chest. And so you can see with the camera, the stapler coming in. And this stapler will fire 6 rows of really tiny staples that are alternating and then cut in between. So that means 3 rows are left on the stay side inside the patient, and then 3 rows will come out with the specimen. You can see we're really careful when we're dividing branches of the pulmonary artery. So that stapler will close and fire around that pulmonary artery and leave the left lower lobe a little more separated from the rest of the lung. So in conclusion, small lung cancers are increasingly found on our screening and diagnostic scans, and we developed innovative surgical techniques to adapt to this changing landscape, including sublobar resections, tumor localization techniques, and advances in robotic surgery, with the overall goal to improve our oncologic outcomes, but also focusing on better patient recovery after surgery. Thank you so much. I'll give a quick thanks to our thoracic surgery team, most of whom you will meet at this conference, as well as our research team, who has prepared a lot of posters to show and share with you tomorrow. I'd like to introduce Joel Neal back to the stage, one of my colleagues in medical oncology, to talk about treatment of patients with driver mutations. Thank you.